Imagine being a kid and your kidneys just stop working. Suddenly, your whole world is turned upside down. Life becomes about treatments, about being hooked up to a machine that keeps you alive. But here's the crazy part. What if the go-to treatment, the standard first step doctors take, was actually the most dangerous one? Let's get into this really critical medical paradox. Yeah, it's a really tough question, and it gets right to the heart of a huge challenge in pediatric medicine. We're going to unpack why the most common method for connecting kids to dialysis machines is also the one that comes with the highest risks, and importantly, what's being done to change that. So let's back up a little for some context. We're talking about a condition called end-stage renal disease, or ESRD. Basically, it means a child's kidneys have stopped doing their essential job of cleaning the blood. When that happens, they need something to take over, and for many, that something is hemodialysis, a machine that literally does the work the kidneys can't. It is an absolute lifesaver. And this isn't some super rare thing. 51.2%, so more than half of all kids who start treatment for kidney failure begin with hemodialysis. This makes the way they get connected to that machine, what doctors call their vascular access, one of the most critical decisions in their entire course of care. Okay, so that brings us to the big question. How do you connect a child to that machine? There are really two main ways to do it. Two lifelines, if you will. On one side, you have the central venous catheter, and on the other, the arteriovenous fistula. Let's break down what these are. The central venous catheter, or CVC, is pretty much what it sounds like. It's a plastic tube that gets inserted directly into a large vein in the neck, chest, or leg. Think of it as a ready-made port. The big advantage? It can be put in and used almost right away, which is obviously a huge deal in an emergency. It's the fast-track option. Now, the arteriovenous fistula, or AVF, is a whole different ballgame. This is a surgical procedure where a doctor connects an artery directly to a vein, usually in the arm. This forces the high-pressure blood from the artery into the vein, making that vein bigger and stronger over a few weeks or months. It creates a natural, super durable access point right under the skin. It's not a temporary fix, it's custom-built to last. So when you put them side by side, the trade-offs are just, wow, they're stark. The catheter is fast, but it's risky. It's prone to really serious infections and blood clots, and it just doesn't last very long. The fistula, on the other hand, takes time and surgery, but it is vastly safer and built to last for years. It's speed versus safety, really. And when you look at the science, there's a clear winner for long-term health. And I'm not talking about a small difference in risk here. It is staggering. The data shows that kids with a catheter have a risk of being hospitalized for an infection that is 4.74 times higher than kids with a fistula. That's not a minor detail. That is a massive, massive gap in patient safety. Okay, so you'd think, right? One option is way safer. So obviously, that's what doctors choose. But that's where things get really strange. This is the paradox. Despite all the evidence, the safer, more durable option consistently gets pushed to the side. And it's not like the experts are quiet about this. You've got these official guidelines from groups like the National Kidney Foundation, and they're crystal clear. They say that for any child who's probably going to be on dialysis for more than a year, the fistula should be the #1 choice. The medical community actually agrees on what's best. And yet, over 80%, let that sink in for a second, more than 4 out of every 5 kids who start hemodialysis do it with a catheter. This number has been stuck this high for more than a decade, flying directly in the face of what the official recommendations say. And you can see it right here. When you look at how kids start dialysis, the bar for catheters is just huge. And the safer option, the fistula, it's just this tiny little sliver. This is the paradox in plain sight. Which, of course, leads us to the billion-dollar question. If everyone agrees the fistula is better for the long haul, why on earth is it so rarely the first choice? Why are we defaulting to the riskier option? All right, to figure this out, we have to dig into the why. And it turns out it's not one single thing. It's a whole bunch of complex, interconnected reasons that are stopping the better option from becoming the standard one. First up, you've got some real technical hurdles. I mean, we're talking about performing delicate surgery on little kids with tiny blood vessels. It's tough. Then there are systemic problems. Sometimes the kidney specialists and the surgeons just aren't communicating well, or there's no clear process for getting a child referred early enough. And finally, you have the human element, the very real fear that kids and parents have about the 2 needle sticks needed for every single dialysis session, and even concerns about how the fistula might look on their arm. But that whole fear of needles thing, it's really interesting because someone did a study and actually asked the kids who already had a fistula what they thought. And you know what they said? A whopping 95% of them said there's no way they'd want to go back to a catheter. Once they've lived with the better option, they don't want to give it up. Okay, so we know the problems. The big question is, how do we fix this? Well, the good news is there are dedicated groups working on this right now, trying to change the standard of care and forge a better path for these kids. A key group leading the charge is the International Pediatric Fistula First Initiative. It was created for this exact reason, to get the word out to doctors, nurses, surgeons, and families that the fistula is the best choice for long-term dialysis in children and to push for its use. And their game plan is pretty straightforward, but it's really powerful. Step 1. Get kids to a surgeon way earlier, like 6 months before they're even expected to start dialysis. Step 2. Make sure the whole medical team is actually talking to each other. And step 3, and this is a big one, empower families with the education they need to really get the long-term benefits of a fistula and help them work through those initial fears. And this is so important because this isn't about a treatment that lasts a few months. We're talking about a decision that impacts a child's entire life. Most of these kids will get a kidney transplant, but many will eventually need dialysis again down the road. That very first choice about their access can damage their veins forever, closing off options for the future. Which kind of leaves us with this one big thought, right? In pediatric dialysis, the science is totally clear. We know the safer path. The real challenge isn't discovering the best treatment, it's actually doing it. And it makes you wonder, not just here, but across all of medicine, when we know what the best care is, what does it really take to make it the standard care for every single person who needs it?